Good afternoon and a very warm welcome to all of you to the National Snakebite Awareness Summit, a very special show brought to you by the ISW Council and Bharat Serums and Vaccines Limited. Every year, over 10 lakh snake bites occur in India, killing 60,000 people and leaving another 1.5 to 2 lakh people with permanent disabilities. In a country where the king cobra is revered, there is little or no knowledge about snake bites and the best way to treat them. Popular cinema and literature sometimes have perpetuated superstitions which come in the way of timely treatment. The only treatment for snake bite is antivenom, which must be administered by a trained medical professional. If done so, snake bite is completely curable disease. One of the major challenges at the hospital stage is the lack of anti-venom availability. If snakebite victims are able to overcome these obstacles, they are frequently confronted with a medical fraternity that is fully equipped to treat snakebite, that victims are frequently shuttled between hospitals with several succumbing in transit. Having the right knowledge of traditional Indian snake bites can help save thousands of lives every year. To create awareness about this, ISW Council is bringing India's finest health experts to this show to bring forward the emerging need for effective next generation snake bite therapy in India. Please join me in welcoming our expert panel. Please welcome Ms. Vinita Srivastav, advisor, Tribal Health Cell, Ministry of Tribal Health Affairs, Dr. Preetam Roy, Public Health Specialist, Dr. Priyanka Kadam, President, Founder, Snakebite Healing and Education Society, Dr. Choi Kumar Jatma, Deputy Director General and Nodal Scientist, ICMR NTF for Research on Snakebite, Dr. Jules Louis, IUCN Viper Specialist Group, Mr. Ganeshwar CH, Water Snakebite Mitigation, Madras Crocodile Bank Trust, and Mr. Chetan Raj Singh, Vice President, Critical Care and Emergency Medicine, Bharat Serums and Vaccines Limited. A warm welcome to all of you. Thank you all for joining us. It's a pleasure to have you with us on the show. Now, Priyanka ma'am, let me start with you. Is it true that snakebite doesn't receive a lot of attention because it is the poor man's occupational disease, affecting impoverished farmers and families in rural areas? Because in our urban centers, we don't see snakes. We don't see snakes in our parks or maybe next to our concrete homes that we have. We live in a concrete jungle of many large cities in our country. But is that the reason why snake bites don't receive a lot of attention? Would request you, Priyanka ma'am, to please unmute yourself.
Okay. Can you hear me now?
Yes, please go ahead.
Okay. Thank you very much for your question. And yes, snake bite is a very, very big issue in the rural belts of India, also the semi-urban belts. But it is not true that there are no snakes in the urban areas. In fact, sometimes I feel that there is a increase in the snake population in many of the suburban areas of big cities. There are many incidents, especially now when there is flooding and all that, you have so many sightings. So I don't think, it is a disconnected thought that only the rural people or only the farmers are the ones who are, getting bitten. But if you look at the profile of the snake bite victim, the majority of the people are the ones who are working closer to the soil. And therefore, the people who do menial work, people who are working in the fields, who are going to collect firewood, who live in fragile houses, mud houses or houses which are, which have, mud flooring or, unplastered dwellings. These are the people who are maximum exposed to snake bites. And they are, of course, from a very underprivileged background. That is why they are living in that kind of a condition. And so, yes, it won't be wrong if we say that it is a poor man's disease. But, let's look at this as a issue which is all across India. And I don't think you and me are not exposed to snake bites.
Let's hope so. But why just you and me? Let's hope everybody in our country is not exposed to snake bites. And if they are exposed, unfortunately, they get the right medical attention so that they are able to deal with the problems that come with snake bites and able to get effective treatment. Now, Vinita ma'am, tribal districts account for about 70% of snake bite cases. Does the Ministry of Tribal Affairs plan to come up with a national action plan to effectively prevent and manage the snake bite burden in these
So thanks, Simani, for the same. And as you heard earlier, with my speaker said about that, it is mostly attached to the soil. And when we talk about soil, it is tribal. Okay, so Jal Jeevan Jungle. तीन चीजों से tribals are being connected. So the concern is, yes, that the tribal action plan should talk about snake bite, and it is there. So recently we had a ministry meeting with the Ministry of Health, Ayush, and other ministries also to come up with a snake bite action plan, which is going to be there in the pipeline very soon. We have discussed, the first meeting is over. The second meeting is going to happen in a coming or next coming week. That is due. And the minutes circulated says about the joint action plans of these ministries. So now our concern is that how we are going to take up these issues with the tribals. So we have tribal healers, we have community mobilizers, we have community leaders as well. So now the time is that we need to train them. Time is to, we need to train them. Exactly, the infrastructure should be like that. That, as we were talking, that anytime when the snake bite is that there's no referral treatment mechanism, the environment is a problem. But now this should be taken care at the PSC level. Everything like drugs, treatment should be available with the rapid transport, which is the idea. Thank you.
All right. I wanted to ask Ms. Louis, is there a gap between the number of snake bite deaths reported from direct surveys and official data? Is this true?
See,
is there a gap?
it is only CBHI which is collecting data for the snake bites. You all know about it. But exactly, there can be a discrimination between the data about what NFHS is doing, what CBHI, because that data is only the data which we have. So we cannot say in the country like us that everything has been reported. Very frankly speaking, sometimes it happens, the person dies on the way, it has not been reported. Maximum, even in the case of RCH also it happens. So these things has to be kept in mind. So that's why I talked about the rapid transport and other things, which is very important now. So the data which is coming up, we need to have specific plans and specific, like in NFHS, there should be a detail of it, which is not there. So now, when we were talking about the action plan, we have also said that NFHS has to take care of this, and there should be an entry of snake bites in the NFHS data as well. So this is being taken up.
Right. Mr. Louis, in your experience, what is the kind of gap that exists between the number of reported deaths because of snake bite and the actual numbers on the ground? Because in my introduction, I said that 60,000 people are dying. That itself is a huge number. In your mind, is there, ma'am is also saying there could be a gap. How much is the
gap? Thank you. And the gap is very much, actually. For records, in 2019 November, there was a parliamentary question about the number of snake bites in India. And the report submitted was roughly about 3,500 snake bites across the country over a couple of years. That was the data which was submitted to the parliament. And interestingly, that report never had any information from states like Assam or from Nagaland and Kerala. There were 0 snake bites reported. In some states like UP and all, there were 20 or 30 or, roughly in few hundreds. So that, forced my team to do a bit of a survey, and we started doing a survey in last 1 year, just looking at Hindi newspaper articles where, when you search for snake bites, when you do a scientific search, using snake bite as a search thing, you will not get much of data even from Google. But when you do we developed a search bot and done some in-depth search, Very interestingly, from Hindi local newspapers and the small updates, Sarpdams is a very common thing. Every day we get 3 or 4 updates from various parts of the country. And this is again things which came online in a Hindi vernacular platform. So that itself is showing that the number of snakebite cases reported in the government healthcare system or government record system and the actual number of deaths there is a huge gap. Unless and until we record all these numbers, we may not know that how many snakebite deaths happened. Other problem is that when we analyzed this, about more than 50%, about 60 to 70% of this snakebite deaths, the patient never reached the hospital. They all went to a traditional healer. So this is again not going to be captured in any medical records that these people are not. Again, I'm reminding that this is only data coming from Hindi belt and where it is reported online in some platform. It may be a newspaper or anything. So if you're looking at these two aspects of the data, it's very clear that the actual data is much more than what we know about, and the problem is much bigger. The 50,000 number coming from is a result of a systematic study, and that is roughly calculating, probably that is the number, but the actual number could be much higher. And these are deaths again, which we are talking about. But what about the morbidities or other injuries which are a result of snake bites? That's also not captured. So when you capture all this data in a systematic way with help from various agencies and various ministries, the number will be much higher, and you will be actually looking at a larger problem. And I will conclude saying that which could have been stopped, and as my co-speaker said very correctly, something which could have been treated at a PHC level with a few vials of antivenom and a good doctor, and we are losing this many number of people. So it's bigger than what we think. Let me complete this. This probably, I should say, this is a shadow of the tip of the iceberg, what we are talking about.
All right. So the magnitude of the problem is huge. Priyanka ma'am, would you like to add something about the data gathering, the difference in what is being reported and what is happening on the ground? Very quickly, if you could tell us what you want to add.
Quickly, I was looking at the state-wise cases and mortality on the Ministry of Health and Family Welfare. And what was reported for 2021 was 626 deaths. And the number of incidents was 1,26,027. But actually, if you look at the number of snakebite compensation which West Bengal has given in 21 is more than 600. So just one state has, given that many compensations for death by snakebite. And that's why, what Jose mentioned about, there being a big disparity is when you look at the various sources and you collate and you realize that, there is a complete disconnect. Thank you.
All right. So there is a big disconnect in the numbers being reported of snakebite and snakebite deaths and the official data of the numbers being affected. Now, Ganesh, while our healthcare systems need to develop a holistic approach to manage snakebite in a good way, can snake bites be prevented? Is there enough awareness about
that? Snake bites are diseases which are easily preventable. But to answer to the later part of the question, is there enough awareness among communities? I would say no, because it's a huge population in the country, and snakes have always been on the mythical parts and on the negative parts of people's mindsets, and it's been so little information that people learn about snakes that if they see a snake, they can only think about death or killing it. So it's been very little about awareness. And then indeed, snake bites can be prevented. You can see the complexities. I mean, maybe further down the conversation also we'll understand the complexities in treatment, complexities in making better antivenom, complexities in reporting. All seems like a really long shot for now, but awareness, whereas making people understand the fact that snake bites are preventable if they just wear proper footwear, use torchlights in the night, sleep indoors. When sleeping outdoors, use mosquito nets. Very simple lifestyle practices. If people are able to understand this, we have experimented this in the past in a couple of villages. We have written scientific publications to prove that people are accepting to change. Just that you need interventions which are specific to regions in small scales and sort of improve people's understanding towards snakes. And it's very easy for people to ignore snakes. It's because it's not a big animal for them to encounter very easily, unless and until a snake is provoker and it's not bitten. It doesn't bite. So it's easy for people to easily ignore the snakes. It's just that education needs to be in place, which of course hasn't been on the top priority for several years now. But yeah, snake bites are preventable diseases, and with right information that's spread across communities, I'm sure we could reduce a large amount of snake bite deaths in India.
All right. Dr. Pritam Roy, how much is this awareness or the lack of awareness the problem? Because, I remember seeing some very old films where the heroine was bit by a venomous snake, and the hero sucked the venom out of her leg, and, he saved her, and he was also alive. So, when you see these kind of things, you don't think of snake bite in a, treatment as a scientific one. I think, let's go to a local practitioner, let's do these crazy things, because these crazy things are what you remember. Is there misinformation also about snake bite and how it should be treated?
My experience while working in this field is that there is a two component. One is actual a lack of awareness, and there is another part which is a firm belief that they have. So the firm believe that maybe going to certain health facilities, to certain traditional healers may improve, because that has come into their mind generation after generation. So it's very difficult on a one go to move away. And then what you say that the movies jumping to suck the blood and trying to do something, and maybe uh, floating them in the river. So these are actually one of the major problems. Some another component is that they are actually not aware about what to do immediately after the bite. So they are helpless, and then they try to seek help from others nearby, and they get misguided. So that's another type of misconception that we have seen. Another important thing is what to do and what not to do. So maybe we are working with a lot of associations who are concerned with the first aid for different diseases. Even for snake bite, that's very important. Like immediately what you should do, what you shouldn't do, that we must make aware to the people. And then it's not necessary for management of snake bite cases to catch the snake or to bring the dead snake to the hospital or to the clinician. It's not required at all. The clinician can manage the case based on the symptoms that is appearing in the patient and with other diagnostics. So that is another dangerous thing, that going to catch that snake or searching for the snake, that not only delays but provokes another person to get the snake bites. So that's one point. And another is that what we feel is what the previous speaker also told about, that what situations or environments can lead to the snake bites. I think if we can make more people aware about that, that don't keep anything which attracts rodents or rats in your home or houses. So if that comes, the snake also comes to catch and have it, that rats, and that includes this snake human conflict and leads to snake bites while going out in the night. So awareness of using some boots, sticks, using lights. So those are things, those who are working in the fields in the rainy seasons, so can have something as a footwear which can prevent, like some made of cement, plastics, or some bags wrapped it in their legs, so that at least some sort of protection is there. I think this type of awareness, if we can make, will definitely reduce the uh, not make zero, but definitely will reduce the incidence of human snake conflict and bites.
Right, and we need to hear more of this so that at least we get the wrong notions out of our minds. Vinita ma'am has something to add here, ma'am. Please go ahead quickly if you have something to add on what you just said.
So I just wanted to say, because when we are talking about these things, these awareness programs are much required. I do agree, but the thing is that when we talk about the tribal, and especially much of the problems is in tribal only. So when we talk about the tribal healers, which we say they misguide, they need to be trained much. They are the right people to be trained properly. If we train them and ask them that their referral should be made, when and where to be made, this is very important. So the misguidance from where it has been initiated, it should be directly to the right concerns. That is the right path should be taken care of. So
what is the government doing about this? Because
that's what I was telling. The training programs, the training modules which are being developed at the Ministry of Health and Ministry of Ayush both. So now we are trying to train our tribal healers. They should be on the right track because they should understand what exactly they have to do. And especially the community mobilizers and the community leaders as well. Everybody has to learn. If in the tribal areas, as I said, jal, jungle, zameen ki baat jab hum karte hain, so it is important that these things, they don't want deforestation, okay? They want to stay there. But if they want to stay there, they also need to learn and understand what exactly has to be done. The tribal healers are one of the important component of this program. And they need to be tracked now. For everything, even at the PSC level also, we need to track these people. Otherwise, it will not be possible for any of the program until they are being taken into consideration.
Yeah, very important point. That while it's good to have awareness amongst people, and healthcare practitioners need to be ready to treat. Once they get a reference, those given the reference should also be aware about what should be done and what is the best way of treatment. Chetan, what is Bharat Serums doing to ensure the access to anti-snake venoms across India is easier? Is there an issue on access as well?
Yeah, thank you, Anisha, for the question. I was hearing out all the eminent panelists, and they rightly identified the gaps. And I believe in last 10 years, a lot has been done in this space, where government as well as the NGOs are doing a lot of work in spreading awareness. But awareness only is not good enough. Access is something which is really going to address the challenge. So while there are 4 manufacturer in India, a major manufacturer who produces anti-snake venom serum, which is the right treatment for snake bite. But as a Bharat Serum, as a corporate, or BSV, what we thought of is not only a production is one part. According to ICMR, there are 2.5 million doses are required, or approx doses are required to address the snake bites cases in India, which reaches to the facility. And out of that, BSV has got capacity of manufacturing 2 million doses. So kind of 18 or 85% of required doses, we are capable of making it. But making the doses is not good enough. I need to make it available to the patients which they really require. For example, tier 2 and tier 3. So what we have right now in place, we have got 200 field personnel who are there on ground, majorly covering 400 plus districts, 600 cities, and spreading not only the awareness about the right treatment, but they also speaking about where all the anti-snake venom is available. That's one thing. So while our people are taking the medicine to those places and awareness into those cities, similarly, same time, if the medicine needs to be available there. So we got a strong network of distributors. For example, we got some 300 small and big stockists or distributor across the country who ensures that this is available on every 24/7, because this is an emergency. Nobody can plan such emergency, so it has to be available with a chemist or a distributor who can supply whenever it's required. And we also not know, our team of 200 people is meeting around 20,000 general practitioners or the doctors who are treating snake bites across the country. So we are ensuring that the right drug, right dose being given to these deserving patients. Apart from that, we as a BSV have tied up with NGOs like SHE, which headed by Dr. Penka, and with JOS. We are ensuring that whenever, I remember many times when in the night in tribal areas where my people sometimes do not get access of mobile, but these are the 2 gentlemen sitting over here, and Priyanka ma'am, they always keep calling in the night, and there's some patient who require ASVF. So we ensure that even in night at 2 o'clock, that medicine being served those deserving patients.
Mm-hmm. All right. Mr. John, I want to ask you, we heard Dr. Pitambara tell us that, it's not necessary to catch the specific snake after a snake bite. It's most important to rush the patient to a medical practitioner when an antivenom may be available. Does intra-species variation of venom in different geographies of India complicate the treatment of snake bites?
Was that question to me?
Yes.
Oh,
This is
okay.
the question to you.
Yeah. So in the different species of snakes across the country do have different types of venom, and the impact of venom is different. I mean, there are already studies done by various scientists. It's already proven that not only the species level but also regional level there is venom difference. Like the venom of the Russell's viper from Tamil Nadu will be different from the venom of Russell's viper in West Bengal. But unfortunately, at this point of time, for any venomous snake bite, we do have this polyvalent antivenom, which is a combination of antivenom combinations of cobra, Russell's viper, and the scale viper, and common crate. So if you are bitten by any venomous snake in India, you are given a polyvalent antivenom to the patient, which is effective and which is successful in neutralizing venom and saving lives. But there are studies, there are efforts going towards monovalent antivenom, that a species specific antivenom, and also there are talks about regional specific antivenom, because there is a concern because most of the antivenoms are manufactured with the venom produced from one or two regions, so which is also affecting the efficacy of antivenoms. But the country should have monovalent antivenom. That should be our goal. But currently, let us look at whether it is any species. Are we able to? I'm going back to the previous question. Are we able to provide the current antivenom to people, which is almost for last 100 years? This very antivenoms are saving hundreds of thousands of lives every year. So I think our first concern should be effective delivery of antivenom and effective treatment, effective first aid, so that the mortality will be reduced. And then we should go forward for monovalent or regional specific antivenom so that it can further come down. So let us deal with the current challenges and then go towards species specific antivenoms. Yes, species specific antivenoms are a requirement.
All right. Dr. Joy Kumar, do the current standard treatment guidelines for snakebite management by the government, are they sufficient to achieve the WHO's mission of about 50% reduction of deaths and disabilities by 2030? Do you need to revise the numbers or the standard treatment guidelines itself?
Yes. Am I audible?
Yes, sir. Please go ahead.
Yeah. I was just also listening to the previous speaker. They have explained about the magnitude of the problem also, and which the problem could be much more what we are seeing at this moment of time. But to come to your specific questions, that whether this current standard treatment protocol giving the polyvalent anti-snake venom would achieve the target of WHO of reducing 50% of the snake bite mortality and morbidity by 2030. It said the strategy is very optimistic, and even this polyvalent anti-snake venom, which is more than 100 years old, manufactured in our country indigenously, it's a time-tested treatment for snake bite management. As previous speaker also highlighted, that awareness is very important and snake bite is preventable. So it's a multi-pronged approach, not only giving right treatment at right time and right dose, but the creation of awareness to the people so that snake bite can be prevented before the person get the bite. It's also important. Talking to the this snake bite, polyvalent snake bite. These cover four big species of snakes, and majority of the snake bite in our country, as per research, were found to be from these big four species. So taking that into account, that was consideration to produce polyvalent antivenom for treatment of snake bite. And almost more than 80% of the cases happen to be from these big four, although there are regional specific medically important snakes. They do have happen to be bitten to the people. But this polyvalent anti-snake venom is definitely quite enough to treat the snake bite at this present scenario. And if we make it more accessible at the right moment of time and is given to the right person who has been bitten. I mean, majority of the snake bite even do not require anti-snake venom, because as you know, there are, out of the total snake bites, only 20 to 30% are venomous bite. And majority of these cases need proper counseling and observation. And who is happen to be a venomous snake bite, then only they need to be given from treatment of anti-snake venom. So this polyvalent anti-snake venom is quite enough for the treatment. Right. Coming to other point, like as your topic is to, next generation snake bite. So, like for improving treatment, we have to have two approaches. First of all, we have to improve our diagnosis. Now, snake bite is diagnosed on syndromic approach, and a syndromic approach, and we do not have specific any method of molecular diagnosis like kits and all these things. Only throughout the world, one country have a molecular diagnostic kit, which is Australia. And the other point is, giving immediate treatment to the people. But as you also already told, that snake bite happened to be in the rural area, and some my previous speaker told that we should be treating snake bite at the PHC level. That's a good idea. But however, snake bite is a medical emergency. When any poisonous snake bite to anybody, two type of emergency medical situation happen, because mainly two type of toxicity can happen. One is neurotoxic and one is hematotoxic. Taking that into account, hematotoxic is more, neurotoxic is more important, because if neurotoxicity happen, the person need to be stabilized very immediately, because if he get paralyzed, respiratory system goes, he will die before the poison kill him. So the other way is round, to have a improvement in the health infrastructure, because PHC cannot deal with neurotoxic bite. Either they need to reach to the CHC level or even district hospital level, where ventilatory system can be given, immediate intervention can be given to restore the neurotoxic paralysis effect. But on as a whole, if you treat snake bite properly in proper right time, and with this current polyvalent anti-snake venom, definitely we can achieve the goal of reducing 50% morbidity and mortality, provided that we also take other strategies of making awareness to the people, and improving our healthcare infrastructure, and even referring the patient to, and even like Dr. Benita Madam has already told, it's in the soil tribal population in rural areas. Yes. They are attached with the land and forest, because many a time snake bite happen due to occupational hazard, because people go to the field area, they are encountered with the just to I may be taking a lot of time, but snake do not bite you as an enemy. They have that much thing that they will bite you as an enemy. Most of the bite happen when we come in contact with them as an either defensive bite, that is when we come in contact they want to defend themselves. The other bite happen to be is offensive bite, when they come for looking their prey in your house, like rodent and all these things in the rural areas. As you know, Priyanka already explained the mud house, they are how exposed to these things. So in this way, encounter with the snake happen, and then a bite has happened. So what I would like to give the message is that definitely if we take all these strategies, even with the present polyvalent anti-snake venom, we will be able to achieve the target to reduce the morbidity as well as mortality to 50%.
All right. Priyanka, in your mind, what is the most successful model to mitigate snakebite problems, and what's the best treatment in your experience?
So thank you for this question. And any program, any health-related program, you have to work with the government. Small NGOs like ourselves, no matter what we do and how much we do, it is not enough because our country is really large and it has very complex issues. So working with the government, and that also at the district level, is very important. Recently I was speaking to a collector in MP. We have started working a lot in MP, and the collector said that we don't have that kind of an issue because all our PHCs have antivenom. And going back to another speaker who said that in all the PHCs, these are all absolutely important points, but is the PHC actually giving that treatment? And I would like to, respectfully disagree with what Dr. Chakma said about PHC not being equipped to treat neurotoxic bites. PHCs also have, ambu bags, for example, face masks. And these are very much, anywhere where I have seen a courageous doctor treating and using ambu bags and treating neurotoxic, bites, it has been successful. Just a loading dose of antivenom and an ambu bag, which will, be a ventilatory support, and then refer the patient to a higher hospital. That is really going to actually save lives. So the successful model is to work through the district, through the Zilla Parishad network, awareness in communities, and building the infrastructure. When I say that, it means not just the infrastructure of giving antivenom or having ventilators and things like that, but also training the staff. And one thing quickly I want to point out is that in India, snakebite is a medico-legal case. So, and only doctors can treat snake bites. Now, when you actually go on the ground and visit PHCs, there are many PHCs in the interiors, where you will hardly find, a doctor. Or if a doctor is there, it's just one person and he has to do 10,000 things. So it becomes really tough to, put the responsibility and say that, the PHC did not do their work. I think if we are able to tweak this a little bit and include the nursing staff also, when the nurses are capable of handling deliveries, that is also a life-threatening situation. A person can die during a delivery. But when you are able to give them that kind of a responsibility, then why not train a nurse to manage snake bites? So that is something that I really want to highlight.
Right. So we've heard Vanita ma'am talk about training for tribal health practitioners, and perhaps this variation also needs to be brought about. Dr. Preetham has raised his hand, so very quickly, please go ahead and tell us what thoughts you have.
Yeah, just I think I will not take much time, or maybe just one of my concluding statement may be taken as like the snake bite management should be taken in a broad way. As my previous speaker also emphasized, I fully agree with that. That not only doctors but nurses needs to be trained, and that's very important because it's a team management. And the snake bite management is not only about administration of AVS. It is more beyond that. The first aid, then looking and managing the neurotoxic other manifestation. So not only AVS, but giving the atropine, neostigmine along with that. If it is a hemotoxic, whether we are looking at the renal failure or not, whether we are managing that thing or not, if there are bites, if there are complications, wound, whether we are giving appropriate antibiotics to manage that not. So these all very, very important. If atropine neostigmine is not working for Krebs, then are we going for calcium gluconate, the ventilator support? And if the patient survival and chances of without post-morbidity, post-bite morbidity depends upon not only a correct dosage of AVS, but also the supportive management that is given to the patient. So I think that is also very important, and we cannot say that not giving those supportive management, and if the treatment deteriorates or anything, we blame only on the AVS. So AVS will do a certain part of thing, but other part of the management also needs to be taken care, and failure of that cannot be given to AVS per se. So that's one of the important message I think we should all have while the managing snakebite management. Thank you.
All right. All right. Dr. Joy Kumar wants to add something. Dr. Kumar, I also have a question to you, because we are talking about disabilities because of snake bites, and how that should be blame on the AVS. But I want to understand from you, when it comes to these disabilities because of snake bites, does there need to be a uniform compensation by the government and easy accessibility to these funds?
Yeah, just to give little clarification to what I said previously, as Dr. Priyanka also said, what I mean to say that treatment of snakebite, as Dr. Pritam also highlighted, the treatment initiation of the treatment, giving first dose first aid is important, and also initial dose of giving ESB is important. But in case of neurotoxic bite, you need immediate interventions. She said, okay, many of the primary healthcare center, they do have those facilities giving some respiratory support and all these things. But transport to higher level is also important. What I mean is complete treatment with management of the complication is required at the higher level of center, which is also very important, which is highlighted by Dr. Pritam already there, and which lead to disability and also mortality. The other point here to discuss is Dr. Pritam clearly indicated that do not blame only ASB is not working, because the supportive treatment is very much important. Maintenance of ARO is very much important than giving the dose of ASB. Suppose, I will just give you an example. One patient of neurotoxic bite research to the PhD, you gave the ASB without keeping the basic life support, like keeping pet in the ARO and respiratory support. That will not give the result of giving the ASB. So in that way, Dr. Pritam very clearly saying that only ASB will not improve your treatment. The other supportive treatment and better management of the patient will definitely yield good result. And coming to your question, that disability, yes, although Government of India, even if many of the state government has different provision of giving compensation to the snake bite victim through different acts, even some disaster management act, somebody from health ministry giving the compensation to the patient. So when snake bite happen, there is, the fear is there that snake bite when happen, it's a poisonous snake bite. The uncertainty to the people that whether he would survive or not. That's a very important thing. What we call post-traumatic shock syndrome happened to the people in the rural area. They do not have that much of knowledge where to get the treatment. As you know, 70% of the cases do not reach to the hospital. That is because of the lack of awareness, where to go. And then the firm belief, as my previous speaker already pointed out, that they go to the traditional healer. Here, even role of traditional healer become important, and Dr. Srivastava Madam already pointed out that why they are important is because, as I already pointed out, majority of the cases of snake bite are not poisonous bite. Yeah, and they happen to be in the rural areas. And why they become important is majority of the snake bite, at least more than 50% of cases, are not poisonous, and many a time even poisonous, they happen to be dry bite. But when they reaches to the tribal healer, if it is happen to be a non-poisonous bite, the tribal healer will do his jar cook and all these things, and whatever remedy is available. Then if as I am saying, non-poisonous bite, the patient will recover by itself, and then the firm belief will happen to be that he has cured the patient. This type of myth and need to be busted, and we need to make awareness to the people, and even that does training of the tribal healer become important here. And whenever you find a snake bite cases, yes, you observe it's fine, but immediately refer to the higher center, so that if it is happen to be poisonous, if it is happen to be non-poisonous, it's fine, he will survive. if it is happen to be poisonous bite, so that immediate intervention can be taken for giving supportive treatment, anti-snake venom, and other things like this. And to prevent the for just a moment, to prevent the disability, the treatment, complete treatment, and higher center referral become important, because snake bite is not only toxic to only brain and blood. It's toxic to many other parts of the body, cardiotoxic, neurotoxic, kidney toxic. So disability will come in a very later stage, and if we cannot manage the complication very well, permanent disability will be there. If we do not manage the wound very well, toxicity can cause necrosis, and you have to amputate the limb also. That will give a permanent disability. These are the very critical issues that need to be taken care while giving the complete treatment to the snake bite victim.
All right. Ganeshwar, my question to you is, in your mind, what is the best approach to try to reduce disabilities? Because we've heard that we've got the antivenom, which is very effective. We heard Dr. Joy say that many of the bites are non-venomous. But we want to reduce the disability load as well, because again, compensation, quality of life, all of that is coming into the picture. How can we reduce disabilities because of snake bites?
It's a bit of a clinical question also. I think a doctor would also should add to this. But my opinion towards this is that I believe that disabilities happen when people have a delayed time in getting admitted to hospitals. That something can be addressed through awareness, is that if you go to hospital as soon as you're bitten, there's a good chance for you to get right treatment of antivenom, and which would lead to recovery fast and chance of less disabilities. But and also the fact that a lot of people, before going to hospitals, they go for false first aid, such as cutting, tying something, or maybe using strange methods, which all would imply to the fact that disability can happen to that victim. And all this could be addressed through outreach. But after going to hospitals, we have seen several cases of hospitals going for they're trying to do non-medical ways of treating patients, like they're going for cutting the limb bitten area, trying to give incisions there, trying to remove the pressure, which are not advised by the Indian treatment guidelines. So there are hospitals which still practice some of the old methods, which are not acceptable in this current stage. And that's something maybe a clinician could obviously answer, but from the perspective of a community health workers, or from perspectives of educators, we feel that if we are able to help people understand the basic facts of first aid, which is not anything clinical. The first aid in snakebite is not tying something or applying something on there. It's about keeping the person calm, making sure that bitten area is not moved rigorously or not put into much of action, less blood pressure, and then quickly move the person to a nearby hospital where treatment can be accessible at its best. This could be PHC, a CHC, or at a tertiary care. So I think that's where a lot of morbidity can be addressed, with example to this. But then with places where there is very limited access to healthcare, where there is limited access to ambulance services, it's going to be only difficult for people to find their own transportation and go also. So I think these would also play an important role, is to connect between communities and hospitals, either via public transport or via personal transportation. So awareness would play a role in here, but post reaching to hospitals, a clinician's job would be as crucial in avoiding amputation or any sort of disabilities. And again, defining disability is also important in this case.
All right. Chetan, we just heard Speaker Tala said in our country we don't have molecular testing of what kind of venom has gone into the victim's body. A good quality anti-venom that is effective pan-India is a good one, and we have a combined ABS. So what is the future hope for such an intervention? What kind of innovations are we doing to ensure that the anti-venom is really effective across our country?
Yeah, so as we know that BSV has got the finest lab or R&D lab in India, and just to apprise the group, and BSV is the company which has got more than 15 products, first time in the country or first time in the world kind of thing. So that kind of assurance that we provide to all the SCPs and the professionals. But one thing I can tell you that though all the manufacturers are procuring the venom from one source, but there are the R&D and the manufacturing process which makes the difference in the quality of the product. So Bharat Serum or BSV was the first company who introduced that caprylic acid precipitation method, which ensure the good quality of anti-snake venom. Apart from that, in the last 20 years, we have done a lot of upgradation in our manufacture process, which ensures only the required proteins there in the anti-snake venom, the final product. And we are working on including now nano filtration also as a part of our filtration process, which makes the venom more purest form. I mean, so that's how the unwanted protein is not going to be there, which causes injury to the other organs like kidney and all. So we are ensuring that whoever the receiving our antivenom is the finest form and should not cause any collateral damage to the patient. That's one thing. And as far as in the next session, we have our R&D expert, Dr. Eldon, who is the guy who has been developing this venom, and he knows the best. So he's going to join the second session. He will harp on more on this. But as you asked the question about the future, our only request to the government, whenever I know that government is taking almost all care while providing the medicine to all the victims, but the only request from our end, we need to focus not only while doing a procurement, not only focusing only on the price, but as well on the quality as well. So while you are procuring the venom, you always ask for the quality also, because that gives a motivation to company like BSV to come out with the best of the quality, this without considering the cost factor. So that is something need to be. So while you are asking for the bidding, we always first ask for the technical clarification or the clearance, and then only go for the price. Price comes. So that will give us more motivation to work on more and more, or adding more processes to come out the finest form of ASVS.
All right. Vinita ma'am has something to add here, ma'am. Please go ahead.
Not here, actually. That's very correct that we need to have these specifications there. The specifications for the venoms are not there. If you see these specifications, which we find that these need to be basically revisited, actually. So the second thing which is more important is that at least health system strengthening should be there. Why I'm saying about the health system strengthening? Because every state has its own EDLs, and state venoms are not in EDL sometimes. So if you have specific EDLs into that, then it will be easier for us to procure the good venoms, first of all. Second thing is that specific plans in an execution of snake bites, which is very important. We don't have any specific plans in the PIPs or PACs or the rural areas, Ministry of Rural Development or Ministry of Environment. Never. We never see such things. So these are important things which has to be taken when we talk about venoms, which has to be procured. So these specific plans should be there, and its execution is equally important, which is not there. Third thing which is very important is when I believe one of my previous speakers talk about the rapid transport and the referral mechanism, the standardized protocols and at the secondary and tertiary level. Both things should be there. It's not only one thing. If we are taking care of at PSC level, immediately the rapid transport should be there. That should be from the community. जरूरी नहीं है कि वहाँ पे ambulance पहुँचेगी. So there the mobile ambulance and all come into picture, which is very important, and that has to be taken care of. Treatment and drugs availability at the PSC level is very important, but apart from that, regular monitoring, whether it is there or not. As my previous speaker said, yes, it is in MP, but not in all states. And that too, sometime in MP also, it is lacking. So when it comes into EDL, it has to be there. These are important things that one has to be, distribution of repellents, snake repellents is equally important, I think so, which should be taught to them, because when they stay there, they need to understand how this can be done. And the guidelines and protocol, as we say, it should be as per the WHO standards, which is very important. So if we really want to take up these issues, these are the 5-6 parameters which we take up. And I am dead sure about it that at least 60 to 70% problem is gone. So which the government is already taking care of it. Thank you.
That's a good approach, and it's forward movement. The government is working with its different ministries to get the message across, and I hope a lot of community service, those involved in community service, NGOs will also get into the act along with the government to create this kind of awareness. Now, I also want to understand that how can we innovate to overcome some of these infrastructure issues? Like we are working hard to get good antivenom, training our staff so that disabilities may be prevented by good treatment after the ADS is already given. Chetan, I want to understand from you what other innovations can help. Do you think apps like Serpent can help in addressing these gaps and challenges in snakebite? And should this also be adopted by government agencies? Should we work together? Because once you have people on ground plus government functions working together, then we'll have a better impact of the technologies available.
So technology helps in a lot. Technology helps in R&D, technology helps in all these things. CBHI is the only way where we get the reports, as I said. IDSP takes care of it. And I don't think that is enough. When we talk about the other states, like I was hearing that we got the details from the Hindi newspapers and all. This is a true picture. So
now the question actually is whether the government should adopt some of these technologies like the Serpent app. The question I was asking to Chetan also was this.
It should be adopted. But the thing is that, as Dr. Chakma said, we don't have done the R&D for that. That is very important. When we get to know some app or like we initiated SWAST portal, okay? Then we initiated some other things like NFHS watch, but there was a proper R&D for it. So that needs to be done, and then we can absolutely adopt those apps. It's not an issue. Government never says about they're saying no to it. They just want to know exactly what exactly the app is given. So there a convergence has to be done. A good convergence between the private partnership and the government. The private and so PPP vote can be done, easily doable. And once it is doable, when it is done, then the government can totally adopt it. That is the way. That is. Right. You cannot say that everybody will be part of it. Once it is prepared, then the government has to own it. That is there.
All right, Chetan, quickly, what would you like to add on this? How can we move ahead on this?
So I completely agree with what Dr. Vinita just now said. And my point about this Serpent thing, like you asked the question for innovation. So before going to Serpent, the one idea which was in our mind, for example, most of the victims comes from the areas where like they are working on the soil, with the soil, and like farmers and all. A big giant of or these victim comes from the green belt. So what we were thinking, most of them, we were doing our initial internal survey, we found out there's one thing common among all the farmers is the credit card, Kisan credit card, which they use. I mean, something that they normally get a credit card called KCC. And this is something that's available with them. But like we were talking about the awareness part, wherein there is an ambulance number. I mean, there's an emergency number, even in UP, I found out some 1091 or some number. But those people are not aware of. I mean, whenever the snake bite happens, the first approach that they go for, the healer or that traditional healers in their nearby areas. So if they have one number, even as a helpline, wherein they can contact. So if I can print the number on their credit card itself, Kisan credit card from government side, that whenever there is any snake bite happens, please do reach out to this number. So at least they will get some that with pros and cons in 2 minutes. That no need to go there. I mean, this is the place where you need to go. So that is one of the ideas. Second, then we thought of many times what happens whenever snake bite happens, even they want to go to nearby PSC, Venom is not available. So they wasted going there half an hour, reaching to PSC. Suddenly, either the infrastructure is not available, even infra is available, then the medicine is not available. So as we are talking about that awareness and this access, they are two integral part. And this Serpent app is going to bridge that gap. So this Serpent app is going to give them a clarity, not about where all this treatment available nearby. Also, it will give a access to them that this is the PSC or CSC where the Venom is available.
All right.
So we are working.
Have we started? Just a quick question to you. Have we ever initiated these things in any of these states like UP you talked about? Has UP taken up this initiative or they know about it?
Not yet, ma'am. We just taken an idea from Jose's thing when Kerala took up. Jose can add it to that.
Yeah. No, so Jose has been taken up in Kerala or not?
Yes, it has been taken up. Answer that question.
Vinitha ma'am, let me answer you. We have created a customized version for the Kerala State Forest Department, which is linking the Kerala State Forest Department, the snake rescuers, educators, and hospitals, so that an integrated approach can be there. And there is a successful model which is running last 2 years. I will, after this meeting, I will share the details with you. Hello?
Yes, yes, go ahead.
And ma'am, sorry, Jose, carry on.
Yeah. So this is something which can reduce snakebite incidents. One is to preventing the snakebite incidents, and as the previous speaker Chetan said, it will help people to find the nearest hospitals where snakebite treatment is available. We need the app is only a tool, but we need an integration of work between various agencies to ensure that when they go to a hospital, antivenom is available. We are very happy to partner with the government and take it forward. So it is. I can share the success details from the state of Kerala with the details to you for your kind consideration for future expansion.
That's the thing which I
that's
wanted
how the
to
civil
do,
societies and corporate.
No, the thing is that, Jose, that is very good. Actually, the forest department has taken, why not health? They should also come up with this. I mean, they should adopt this app. And it will be a good convergent point that where the health and the tribal both adopts this app. And then it will be very helpful. And the helpline number is there. I don't know whether the Kisan Patra will be helpful, but we have CSCs. The Common Service Commission centers are there in the districts, you know that. Across 550,000 common service centers are there. And this can be also installed because they have all these facilities of basically putting up the data and everything. If you have heard about NHA and all, these Common Service Commission people have done a great job. So this can be adopted by, this can be integrated with them also. So what I'll do, I will speak to Dr. Ratan Kelkar over there in NHM. And I also speak to the Principal Secretary. I am supposed to come to Kerala actually in the October itself, maybe in the second week of October. So I will take up this issue over there in the meeting itself. And we will try that this app is being adopted by the health as well as the tribal affairs also. So at least once it has been taken up in the state, and then we can replicate in the other states as well. So now the convergence has to be done until unless the good convergence is done among the 3-4 basically ministries. And Ayush should also be there, because what is happening, I was just going through some of the literature from Ayush itself. It says that there are some medicines which can be helpful. So while training our tribal healers and all, apart from the antivenom which is there, this should also be taken into consideration, and your app can also talk about that. So I will speak to our Secretary Ayush about it. I think before coming to Kerala, I will do the needful, and I will inform everybody while I'm coming there, and I think we can take up this matter very soon. No issues with that.
That's great to hear that innovation is being thought about and adopted as quickly as today, as there is an openness to take on new innovations to improve the outcome of treatment for a snake bite. I would like to thank all our esteemed dignitaries for joining us. We are going over time, but I would like to thank all of you for joining us and sharing with us your views on how snake bite treatment can be made most effective in our country. I would like to wrap it up here. Thank you all for joining us, Dr. Joykumar, Priyanka, Chetan, Jose, Mr. Gadeshwar, and Vinitha ma'am, and of course all our dignitaries who joined us. Thank you so much for joining us and sharing your ideas, your views with our audience here. I'm going to wrap it up and hand it over to Riddhi Lakra to take us through the next session.
Thank you. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you so much, Anisha. Hello and a hearty welcome to all of you in the second session of Snakebite Summit 2022, organized by our IHW Council in support by Bharat Serums and Vaccines. I'm Riddhi Lakra, Assistant Editor, IHW.TV. The World Health Organization estimates about 5 million snake bites occur each year. In India, we see cases around 81,000 to 1,38,000 deaths occurring. Snakebite envenom causes as many as almost 4 lakh amputations and other permanent disabilities. While snakebite venoms are effective treatment to prevent or reverse most of the harmful effects of snakebite envenoming, and it should be the part of any primary healthcare package where snakebite occurs. Unfortunately, many people either lack access to antivenom or cannot afford to pay for them, or most of them are unaware of the right treatment. To discuss this topic on snake bites, the right dose, right treatment at the right time, we have and in any snake bite management, we have with us Padma Shri Dr. Umesh Kumar Bharti. He is the state epidemiologist, State Institute of Health and Family Welfare, Department of Health and Family Welfare, Government of Himachal Pradesh. We also have with us Dr. Sadanand Dagadu Raut. He is the MD General Medicine Toxinologist. He is member of Roster of Experts with the WHO. We also have with us Dr. Dayal Bandhu Majumdar. He is a Senior Medical Officer, Calcutta National Medical College, Kolkata. We also have with us Dr. Alden Fernandez. Dr. Fernandez is the Vice President, Research and Development at the Bharat Serums and Vaccines Limited. Joining us another expert, we have Dr. Maya Gopalakrishnan. She is the Associate Professor, Department of Medicine, AIIMS, Jodhpur. The last panelist we have with us, Dr. Anup Kumar. He is a consultant and Chief of Critical Care Medicine, Baby Memorial Hospital. I welcome all of you for this session, second session of the Snakebite Summit. To begin with, I would like to start with Dr. Dr. Bharti, are you here? I think Dr. Bharti has not yet joined us. He'll be joining us. I would like to start with Dr. Raut first. Dr. Raut, like we understand that the Indian and both the WHO guidelines clearly mentions that anti-snake venom should be used judicially, and since it is relatively costly and is limited in supply. So, however, like owing to the fear of the death, a lot of physicians, while treating the patients, they like tend to use. It is mentioned that you should use 10 vials of the anti-snake venom initially, followed by 5 to 10 vials, 6 hours, like for every poisonous snake bite. So, what are the after effects of such liberal usage?
Good afternoon, everybody. All of us know that antivenom is the only specific antidote to snake venom, and most important decision in the management of snake bite victim is whether or not to give antivenom. Antivenom should be given only to the patients in whom its benefits are considered likely to exceed its risks. Since antivenom is relatively costly and often limited supply, it should not be used indiscriminately. The risk of reactions should always be taken into consideration. And everybody of us know that the protocol is in neurotoxic snake bites, we give 10 vials first and maximum 20 vials. And in hemotoxic, 10 vials first within 1 hour. And depending on blood clotting time, another additional vials, maximum up to 30 to 40 vials. And there is no specific contraindications for the anti-snake venom in venomous snake bites. Adrenaline prophylaxis should be used. Polyvalent is the only antivenom available in our country, and many times people are giving test dose and wasting their valuable time. That should be avoided. It should be diluted in a normal saline, and it should never be used intramuscularly and locally also. And close monitoring of vital signs for development of anaphylactic reactions are very important after starting anti-snake venom. So we have to give anti-snake venom only when there are specific indications. Otherwise, there is no use of anti-snake venom. Many times, ASV is given in non-venomous bites. That is also very wrong. And we have to judge the patient by rapid progressive swelling, whole blood clotting time, swelling more than in one joint, swelling after bites on the digits, and local bleeding or necrosis, development of an enlarged and tender lymph nodes. These are some of the indications. In systematic, we have to just any neuroparalytic signs and symptoms, vasculotoxic signs and symptoms, cardiovascular abnormalities, right, irregular pulse, hypotension, shock or arrhythmias, bleeding gums, systemic bleeding anywhere, hematuria, abdominal pain, backache, and vomiting. All these are the indications. Unless and these are there, we should not start anti-snake venom. So there is no need of. So we should not give without these signs and symptoms, neurotoxic signs.
Okay. Thank you, Dr. Raut. Dr. Anup, I would come to you, asking about this, like we understand, like we need a right dosage for antivenom, and that should be administered in any case of a snake bite. And so does all in most of, as Dr. Raut was telling, that not everybody requires an antivenom dose. So when do we require, who requires an antivenom dose, and what are the other side effects of the antivenom dose when it is given to the patients?
As far as the indications are concerned, Dr. Raut has clearly mentioned what are the indications, like in hematotoxic bite, neurotoxic bite, and in local reaction. So one point I want to add in that situation is, like, I'm a critical care physician working in Kerala. So we are getting many Malabar pit viper and again Hamnose pit viper bite cases in Kerala. And like as Jose has mentioned in the last discussion, we already have a WhatsApp group of all these doctors and the herpetologists as well. So whenever we get now with these smartphones, majority of the people are having the smartphones and they are coming up with images of the snake. So even if they are having a coagulopathy, as we all know, our the polyvalent anti-snake venom will not cover for these Hamnose pit viper or other pit vipers. So that is one situation where we don't have to unnecessarily use the anti-snake venom. And other than that, sometimes, like I've even last week we had a patient, that patient was treated outside. They've given up to 30 vials of ASV. Still the coagulation was persisting, and patient was receiving multiple doses of FFP and even the fibrinogen, looking at cryoprecipitate, looking at fibrinogen. So that also you don't have to do. So majority of the time, especially in pit viper bite cases, we will have to accept the coagulopathy. And if the patient is not having any bleeding tendencies, you don't have to treat the numbers. Like you don't have to treat based on the PTINR value or the platelet value or the fibrinogen value. Only if the patient is having a bleeding tendency, then only we have to use these blood products. So along with using like the right dose of these anti-snake venom, the right dose of blood products is also very, very important, and that has to be emphasized, I think. And especially the hospitals, like the corporate hospital or the bigger tertiary level hospitals, where they have access to these blood products and all the investigations. And regarding the side effect, sometimes the common side effect will be the anaphylaxis itself. The patient can develop hypotension or bronchospasm or other the features of anaphylaxis during ASV administration. But if the patient is still having absolute indication for continuing the ASV, you have to continue the ASV in a proper critical care unit, where the critical care physicians who are trained in managing the airways and the hemodynamics are present. So even when the patient develops these anaphylactic reactions, we continue to give these anti-snake venom under an adrenaline infusion. We titrate the adrenaline infusion, and at a slow dose we continue to use anti-snake venom. So because we don't have any other option for that. And other adverse effects like late serum sickness, etc., you can have with these anti-snake venom, but it is not very common. And even sometimes the mild allergic reactions are also possible with the anti-snake venom. So as we have already told, we have to use it appropriately. And another common mistake the majority of the peripheral hospitals commit are, like when we get a referral cases, like they do a whole blood clotting time, and based on the whole blood clotting time alone, they administer anti-snake venom. So you can sometimes get a false whole blood clotting time, especially if the glass tube is not proper or if there any detergent content is there. So you should not take the decision based on only the whole blood clotting time if the patient is absolutely normal, and again you don't have a like any evidence that it is bitten by a like a hematotoxic snake. And another important clue what clinically we can do is, like majority of these hematotoxic snake bite, when they are having the coagulopathy, they will be having a local reaction also. That is, they will be having a swelling at the bitten site. So if you don't have any local reaction, if you are having only like a prolonged whole blood clotting time, I think we can repeat the whole blood clotting time with a control and see that is getting clotted or not. Or definitely, like if you have a like access for other coagulation profiles, you look at the PTINR or APTT, the platelet count or fibrinogen. Or like if you are working in a even like a other tertiary hospital where you have access to all the tests like the advanced coagulation monitoring like TEG or ROTAM, you can even look at that, then decide whether to administer an ASV. So without a local reaction, whenever you are having a prolonged clotting time, or like if 20 minutes all blood clotting time is not getting clotted, definitely there is some problem with your assessment in the whole blood clotting time. So definitely, like if the patient is not sick, you have to repeat that, then you have to decide whether you have to continue with the ASV. And as I've already told, even when you are not the blood is not clotting even after say 20-25 vials of ASV, more than 25 we usually don't give, up to 25. So definitely you have to think about the possibility of pit viper envenomation, and there is no point in continuing the 5 vials of ASV every 6 hours.
Thank you, Dr. Anup. Yes, Dr. Maya, you want to tell something?
First of all, I'd like to thank the organizers for giving me the opportunity. I'm very happy and honored to be here. So I just wanted to add a few things. I think Dr. Raut and definitely I agree with Dr. Anup. He's made very important points regarding misuse of antivenom, which it should not be used at times where it is not indicated. But there is also something which I would like to kind of bring out, that the advice that if there is no local envenoming, then the patient will not probably have a systemic envenoming appears to be a little bit of a regional advice, because here we see viper envenomings, especially Negus envenomings in Rajasthan. What we see is that patients may not have a good amount of local envenoming. The swelling is very limited. In fact, there may not be much of swelling, or swelling has resolved, but patient is bleeding. So I think that has to be taken with the context. So here we have saw-scale viper, which is possibly Echis socioreki, which is considered a subspecies of our Echis carinatus candidus, which is common all over India. So there are some the herpetologists agree and disagree upon whether it's a separate species or is a subspecies. But our experience clinically is that these patients behave very, they do not respond well to antivenom, which is quite similar to Hypnal or Malabar pit viper. So we also have this problem that patients receive antivenom, which is more than 30 vials, 40 vials. So for a periphery, I think the message should be very clear. If we are going to say that at a primary healthcare center, I think the message it should probably be very clear. If we cannot possibly give out the message that just with WBCT don't treat, because that is our current indication for treatment. And second is that usually many of the complex tests are not available, including PTINR, to make a clinical correlation. So yes, but we have to limit the amount of vials which are given. If the patient is not responding in 20 vials, it is painfully clear that he is not going to respond further. So in that case, yes, it's not of any benefit that we keep on giving more and more antivenoms. This is the point which I want.
Yes, thank you, Dr. Maya. Dr. Maya, I want to ask you another part of the question. In terms of there is a problem of myths associated with the snake bite, and a lot of people do not, they tend to seek interventions of the other quacks and all. So how can this be avoided, as like only 30% of the victims are able to reach the hospital, and the place where you work in Jodhpur, and you might have also worked in some other places. So have you also come across such thing, and how do you think we can avoid such myths around snake bites?
So I think it's a very relevant question in the sense it is something which is widespread in the community, that once there is a bite, then a patient first approaches a community or healer or a faith healer or somebody who is locally practicing some kind of local medicine and then gets referred. So personally, my take on this is that if we are going to take a very hard line and say that when patients come to us that you can never go to why did you go to a traditional healer, you should have been here in the beginning, and that kind of thing kind of alienates the management. So I think that it is also in the previous session this point has been brought up. I think many of the traditional healers can be brought into the fold of health system, and while we are strengthening the health system, they must also be made as a part of a community health workers. So in general, we find that these traditional healers are not very averse to referring patients to hospital. Most of them are not advising against. They might do something. So once they are educated and they are in line with the health system, and also if a patient receives that advice from a community person who he or she is very familiar with and has a lot of faith in, rather than us sitting in a tertiary care center whom he is going to see only once in his lifetime. If that person says, okay, please go to the hospital and get ASV, that kind of message, if that person is able to deliver, I think that will be a very good part of strengthening our health system. It should be made a part of the referral chain, so that things can happen much better. I think this part can be explored with the kind of technology which people are talking about, that WhatsApp groups can be there and these people can refer within the health system. Usually they don't want to work against the health system. That is my experience in general. Yes, we need some amount of community education, that ASV is available and ASV is working, and they should reach hospital for that community awareness is happening. And also, if the community awareness comes from the faith healers part, I think that will also improve the setting the message into the community.
Thank you, Dr. Maya. Dr. Umesh Bharti is here. Dr. Bharti, just welcome to the show, and I want to come to you and ask about, like, we were discussing about the various pointers about the anti-venom dose, when it should be given, and the need to increase the awareness about it. Doctor, I want to ask you, as a public health practitioner, and in terms of this, how important is the need to include snake bite as one of the health conditions in the rights of the person with disabilities? How should we include this? Dr. Bharti.
Yeah, good afternoon. I could not hear. Please, can you repeat? I need to go to some other place because a lot of noise in this hall.
Okay.
Can you repeat, please?
Yes, I can repeat it, doctor. So, doctor, as a public health expert, how do you see there is a need to include snake bite as one of the health conditions in the rights of the person with disabilities?
Yeah, this is a very important question. I think most of the time when we talk of snake bite, many of the snakes don't even think they can be the problem in snake bite. Source of disability. So that is very important.
Dr. Umesh, we are not able to hear you. Can we come back to you again in some time? Yes, we'll just come back to you in some time. I would like to go to Dr. Alden. Dr. Alden is here. He is part of the Bharat Serum's Vaccines Limited. And Dr. Alden, I want to come and ask you, like, we were talking about the use of the anti-venom dosage, and like the awareness, creating part of the awareness. So when we talk about this, is there a need for designing more cost-effective anti-venom doses? And in terms of the snake bites, like, do you think we need some more specialized work to be done in this area? And in terms like it is a costly thing, and we cannot like use the wild so easily, and it should be restricted to certain numbers. So in those terms, like, should we have some more cost-effective ways here?
Yeah, Riddhi, one thing we have to understand is most of the snake bites occur in the agrarian section of the population, and they are not very economically prosperous. So as a result, what happens is they have to go and look at financial setup for any treatment, you know. One way of looking at it is designing a more cost-effective antivenom. Currently, we should look at it in two ways. One is cost-effective, and the second is the antivenom dose has to be effective when given to the patient. Currently, in a setup, what happens is they give one dose or one vial, and then the patient is let out. You know, so many a times that dose is not enough for the patient, and then they send them to another hospital. So, and ideally, a larger pack size of an antivenom would help in being cost effective. At the same time, it will be good to be effective for the patient. Both, you know, that would be this thing. So ease of administration, in fact, is another challenge, wherein, you know, you take each 10 ml vial and you start reconstituting and then administering to the patient. So that would be much more effective when you give a higher dose combination. We have all these in intravenous gamma globulins and other products, but for antivenoms, unfortunately, we've been working always since the early 50s with a 10 ml pack size. So pack size would be critical to look at. Another way is, if you look at an effective antivenom, it would be having more regional antivenoms integration into the antivenoms, you know, basically. So what happens is the snakes, unlike any other disease which is treated, like for rabies, the virus is very, very conserved, you know, whereas snakes, the venom components keep differing from region to region. So in India, you have so much geographical diversity, intra and interassay of the venoms, proteins is completely different. So you need regional antivenoms from local snakes. As a result, what would happen is the dose which is given into the patients of antivenoms will be much, much lower when they are more effective. Currently, we are producing venoms using the venoms from Irula, Madras, which is only a one location, and then going ahead and immunizing the horses, and that antidote is made for all India level. So when the number of vials goes down, then it overall, the strategy is the cost of the antivenom for the end user becomes very, very low.
Thank you, Dr. Alden. Dr. Maya, you would like to add some point here?
Yeah, a quick. I'm so happy that Dr. Alden has brought up this regional antivenom in the discussion. So I just have a quick question. So regional antivenom, it can be done in two ways, I think. One is like you can include the venom from our regional pool, just have some venom source from some other places other than like what you mentioned from the Irula cooperative, or maybe a regional antivenom which is specific for the region. So my question is, one, do you think it is actually cost effective if we go for regional antivenoms? Will it be cost effective? Second, is it viable? Like, are there a lot of difficulties in doing this? Like, I'm just asking from a clinician lay person perspective that why are we not doing this already? Is it not cost effective? That's just what I want.
No, Dr. Maya, there are two or three things to this. The first thing is the availability of the venoms. You have to coordinate with each and every state government and go ahead and try getting the venoms from each of these regions. Then immunize the horses, you know, and then develop an antivenom. Unfortunately, the state governments have not been giving licenses for manufacturing. A few state governments have gone ahead and showed a progressive stand, like the Gujarat state government. the West Bengal state government. Otherwise, in Rajasthan and in Maharashtra, it's more of research objective, which is, they have worked out with Dr. Karthik's lab in IISc, wherein, the research use venoms are given. But for making an antivenom, you require huge quantities of venoms, to raise very high titer antibodies, high affinity antibodies with neutralization capabilities. On the cost effectiveness of making this product for a particular region, you cannot make it state specific, but I'm sure when you make it region specific, like say Western zone, Eastern zone, Northern zone, Southern zone, say Central India, yes, there we have to still look at the cost effectiveness on a full scale. But we should be, our conclusion is, there is a possibility that you can make an antivenom which is effective and, not very, very expensive. But we need a lot of hand-holding from the governments. The state governments, after making this, who are the buyers? If I make it for a Western region, the state governments have to have a handshake with us saying that, yes, we will buy this antivenom. Otherwise, what happens to the antivenom? You make an antivenom. You have all the venom licenses and permissions in place. At the end of it, it doesn't reach the end user. No other states are going to use that particular antivenom. So the tender specifications have to change. All those things. So it's a major handshake between the government and the manufacturers.
Thank you so much. I think that is something like probably that is an area where we have to take up for advocacy with regional governments that how important these are, and then probably.
Yeah, actually, we are working very closely with Dr. Karthik and his team at IISc to develop a regional antivenom for the Western region. And so far, we have gone into quite some progression. And probably within a year, you will see some results in that space.
That is a very welcoming news for us, I think. Okay, thank you for sharing that.
Sure, ma'am.
Thank you, Dr. Alden, for that. Also, I would like to come to that as we were discussing about the standard procedures. Like now that we talk about the venom availability and the region-wise, the regional antivenom you were discussing about. Dr. Bharti, if you're here, if you can hear us, I want to come and ask you about like what is the need for standard treatment? Like the standard treatment guidelines, the SOP, and the practical training of the doctors in providing first aid treatment and early management of the snake bite. Like how important is that, and do we need to improvise that?
Yeah, see, early treatment of snake bite is very important, and standardization is also important. But see, this is a very important issue. Like I just came from Northeast. The species there are not at all responding to the antivenom. So again, the standardization would require how effective the antivenom is. If it is not effective, how can you standardize it? So all these things are interlinked. We need to be specific antivenom. Then we need a standardization, snake bite standardization. I think then only we can have a better treatment than what we have now. Over.
Thank
you, Dr. Bharti, for that. Dr. Raut, I would like to add in the same point in terms of the standard protocol of the management and in inexperienced doctors and the not out back and the wall, like the treating these cases. So, do you think we need to come up with like a proper more there is a lot of inappropriate administrations in terms of the anti-snake venom, and a lot of doctors are not experienced. So what do you have to say about this, and how do you think we can improve this? Dr. Raut.
Can you hear me?
Yes, Dr. Raut, I can hear you.
This is actually very right question. Actually, this should be started from the including snake bite in the medical curriculum, because many doctors, till they get their degree or post-graduation degree, they don't know anything about the snake bite. Latestly, some people have started writing this in the books. And though there are protocols available, our STG guideline, national protocol and WHO protocol, this protocol is not reached to many centers. And though books are reached to the center, nobody is using that books for the reference. And the problem issue is that when the medical officer is joining primary health center or sub-center, he just pass intensive, and he's fresh to the in the practice, and he doesn't know about the protocols, and he's not confident about managing the patients also. So he tries to refer the patient, and that too by putting one vial or two vials in a IV saline. And many times we are getting patients in an anaphylactic phase, even though they have a non-venomous bite, and two vials or one vial is started, and within transporting 1 or 2 hours, patient reaches to another hospital in anaphylactic shock. So it is very unnecessary. And if even though they are knowing protocol or they are willing to treat the patients, there are no facilities like good nursing care or ambubag or ventilators available at the primary health centers. So they just start IV and refer patients immediately to another hospital. That is a big mistake. So important point is we have to train these doctors through ICMR or other institutes, and we have started this program in Thane district, and I have given training to the 150 doctors in 2 days workshop. And since last 2 months, the doctors are in constantly touch with us, and they are more confident, and they told me that we have treated 50 venomous snake bites successfully. So this is the end result of the training. So we have to train everywhere doctors. This is very important, and even paramedical staff should be given a basic training how to identify the snake, what are the symptoms, and how to refer the patients to the another hospital. Many times unconscious patients are referred in a ambulance in a prone position, and there are chances of aspiration, and patients are dying on the way. So these are very simple things. Along with the protocol, we should train to the all paramedic staffs and the doctors, and this will definitely help in saving lives of the patients. And this is observed this thing in our area. Important another point is communication amongst the doctors, private doctors and government doctors. They should have good communication while referring patients. They should tell signs and symptoms to the institute where they are referring the patients. So sometimes last second is also important. While entering patients, many times patients are getting in cardiorespiratory arrest, and we have saved such more than 100 patients who entered in our hospital in a cardiorespiratory arrest with immediate CPR. Sometimes there is no time to start IV or ventilator also. So if we are informed earlier, that definitely helps in treating the patients. So this is very important point. So good communication and training to the doctors. And now another point is that due to COVID-19 situation, ventilators are made available at all primary health centers and sub-divisional hospitals and government hospitals. But there is no training to the doctors. Many ventilators are kept unused till date, not used for a single time also. So availability is not a big issue. Only their good distribution to the snake bite prone areas is very important. That will definitely help in managing the patients along with the training. So this is all I think I have to say about this.
Thank you, Dr. Raut, for that. You have mentioned a very important point about like the training the doctors. Though there are equipments, though there are a lot of things available at the hospital, but there is a need for treatment. But there's another aspect to it. Dr. Anup, I want to come and ask you about this. Like before the patient reaches the hospital, like Dr. Raut was mentioning that from one hospital, if the patients are being referred from the first doctor to another doctor, so there's an important communication need to be done. But there is another part, like in terms of the first aid. So what about the quick immediate first aid that needs to be carried, and before we reach a hospital, in terms of the signs and symptoms that we should be careful about when we observe after a snake bite? What should be done like?
The immobilization of the bitten part will be the best first aid we can teach everyone. And again, at the same time, the unnecessary treatment like making a wound at that area and try to squeeze out or suck out the venom, that again can increase the tissue necrosis. We'll never do that. The same way, like all the people are having a practice of putting tight tourniquet. So that also should not be done. Like we have seen many people developing limb ischemia when they are reaching the hospital after 1 hour or even after more, especially when the patients are developing local reaction also along with the the tight tourniquet. So that should not be done. So I think through the media and through all the social media, everything, the public should be taught about how to immobilize the limb, and again what are the methods, and at least like how to put a crepe bandage or even the normal cloth how to put, and why we should not put a tight tourniquet also. So that is also producing many issues. And again, there is other practice of like applying some herbal medicines, etc. That is also seen. But nowadays, especially in Kerala, such practices are very, very minimal. People are coming to the hospital, but this is the one which we commonly observe, that making a cut at the wound site, like they might have seen some movies and all, then like making a cut and squeezing out all the venom. And even some the not trained or qualified the snake rescuers also through social media and all will demonstrate like putting a nick at that point and squeezing out. So that should not be practiced, and that has to be that knowledge has to be the passed to the public as well. And again, a simple first aid method of how to immobilize, and again try to reach the hospital at the earliest. And there are many herbal or local treatment available in different parts. So that is the one which is delaying the patient reaching in the hospital. That also has to be prevented, because the main issue is like majority of the time it may be a non-venomous snake, and they will propagate that information that this is the proper treatment and it will not be having any adverse effect. So that is other like misbelief everybody is having, that whenever we give a like anti-snake venom, that is having many adverse effects and that can last for long. So if you go for these herbal medicines, etc., there will be complete cure. And if you are not using that, then every year you can have a recurrent symptoms, etc. So such misbeliefs should be clarified with proper education. And again, the first aid I've already told, and try to reach the hospital with an ASV facility. That is also very, very important. There is no point in going to many hospitals and wasting your time. Like you should know, like if in one area which is the hospital with an ASV facility, and if they are going to that facility, as Dr. Alden was mentioning before, there is no point in giving 1 or 2 vials of ASV. At least the initial dose of 10 vials should be given, and that dose has to be finished from that hospital. That is another incident what we are usually observing, like Dr. Raut was mentioning. So that they will start the ASV and they will send the patient in a ambulance without the proper the medical team accompanying the patient. And I've seen the patient developing severe anaphylaxis during the transport and developing a cardiorespiratory arrest and or like a developing severe anaphylaxis. And even that ASV may be given for an like unwanted or like not indicated cases. So that also should not be given. I think the best advice will be the hospital where there is a facility to give a ASV, the first dose of ASV should be given and that should be completed. And once the patient is stabilized after that, you shift to a higher center where you have the facility for the better monitoring. And again, if any organ supportive measures are there, that can also be utilized.
Thank you, Dr. Anup. Dr. Raut, you want to add some point to this?
Yes, yes, I shared one slide. We are using this smart bandage instead of tourniquet, and we have distributed this 1,000 smart bandages in snakebite prone villages. So according to this Australian company, they are saying that there is a delay in absorption of venom for the 12 hours. And this bandage is very simple, like a elastic sprain bandage, which is used, and it is applied very easily. And it is having international codes, one rectangle on it. We have to stretch it like that. That rectangle should become square. So this bandage is very useful. We are waiting for the results, and instead of tourniquet, this will be very helpful. Like, I also think that. So this is I want to add this point.
Yes, thank you, Dr. Raut, for that. Yes, Dr. Maya, you want to add something?
I was just curious about the compression bandage. So, to date, the literature suggests that yes, compression bandages do work if they are applied properly. Most of the studies are from Australia, and when there is a little bit of an older study from India where they found that even with good training, usually members of health professional, health workers are also not able to apply it well, not able to apply it properly. So current recommendation, I think, is against asking the public to come in with a bandage. So if it's a pre-made one and if it is cost effective, I think that will kind of. What is your take on this? Because you've been using it for some time. Do you think it's easy to apply and does it require a lot of? How is the learning curve?
Dr. Maya, were you asking this to Dr. Rawat?
Yes. I thought Dr. Rawat would like to elaborate on whether it's very difficult to use or whether there's a, because so far studies have shown that even when well-trained physicians and health workers are not able to apply the compression bandage. So that's why it's the current recommendation is not to apply anything, just shift the patient with immobilization. So because this appears to be something new and maybe it's a pre-made one, that's why I was just curious that how
we are giving training to all medical officers and ASHA workers in our district. More than 3,000 ASHA workers are trained how to apply this bandage, and even for some public and college students like NSS, we have trained them how to apply this bandage. And we are preparing some volunteers in each villages to respond to the snakebite patients. So they are also well trained regarding application of this bandage. So we are hoping that this will be useful.
Thank you, Dr. Rawat and Dr. Maya, for that. Dr. Maya, I want to come to you and ask, like we were discussing about the treatment process. We were discussing about the availability of the bringing the patient from the after a snake bite to the hospital. But I want to come to you and ask, in terms of the infrastructure, what is the level of critical care infrastructure required at both the primary healthcare center to manage the snake bite efficiently? What do you think there's a need for?
This point has already come up well, that now so infrastructure can be looked at in two ways. One is, yes, the physical infrastructure as such, and then comes the let us say the training part and the little how the know-how part of things. So as far as the physical infrastructure is concerned, yes, first is availability of ASP, and then the second is availability of respiratory support. So now both of these are widely available. In our clinical experience, you see that both of these have become widely available. Ventilators have started becoming available, and most of CHCs, in fact, in some PHCs. So I think it's the right time for us in this post-COVID era to use this infrastructure which has already been developed. Oxygen supply is there everywhere. That we train the PHC doctors and CHC doctors for intubation and at least bag and mask, if not intubation, so that early neurotoxic environment patients coming early, if they require airway support, that can be provided at the periphery. And once the airway is secured, I think that is very, the transport becomes very less risky than what it is before. So like Dr. Rouse has mentioned, the positioning during transport, and then sending the patients, Dr. Anup mentioned, sending patients without an adequate healthcare. So these things, to some extent, these things will get help if the airway is secured at the first point. So if we look at things in general, we know that most of the bites are non-venomous. They can be easily managed at the level of primary healthcare center without any disability. Then we come to an envenoming which is not very severe. There is a local envenoming, maybe not systemic envenoming. And in terms of neurotoxic bite, maybe it's a dry bite. So those things can also be monitored. Only those severe patients need referral and appropriate referral at the time. So I think now there is a huge need for us to, the infrastructure is there. It would be good if we have a ventilator, yes, but it is also important that we train the healthcare personnel who are there for appropriate use of those ventilators. Because it's not about the numbers. If we have 2 ventilators, yes, both ventilators might get utilized overnight. So it's more about training and then to know how to refer and when to refer. This is my thinking.
Thank you, Dr. Maya. Dr. Alden, like Dr. Maya was telling about the facilities available. But then there's another part of it, like, do we need to create more awareness around the proper storage and the quality of the antivenom at the hospitals? Is that is also a very important thing here?
Yeah, to some extent, it is a challenge at remote locations on the storage of the products. I'll narrate a very funny story. When I was visiting Rajasthan at one time, and we were visiting some of the shops where they keep the antivenoms, and it was said store at 2 to 8 degrees. So the antivenom vial was stored on 2 to 8 degrees. The outside temperature was 45 to 50 degrees in Rajasthan. So this is the level of education you had to go to sometimes. This was many years back, at least a decade back. But I don't know how things are right now in a rural setup wherein the products are stored. Our quality team keeps looking at regularly the main distributors who are supposed to have very stringent conditions. But once it goes to the local health centers and all, then there are challenges because of continuous power supply issues and other things. But so what we did was we consciously took a stand a decade back to make two types of products. We were earlier into only liquid products, which are stable at around 2 to 8 degrees for 2 years. And that's the reason why we moved into lyophilized products, which can be stored at 25 degrees, which is room temperature for 3 years. We also do aggressive studies, degradation studies at 40 degrees, 3 to 6 months, and we see how the product looks like. But lyophilized products are pretty stable, and those are the products which can, even if there are temperature excursions up to 40 degrees, they are pretty stable.
Thank you, Dr. Alden, for that. As we discussed, this is a very important part about the storage of the of this antivenoms, and then there is another section part of this, like affordability. When we discuss about this affordability, Dr. Bharti, are you here?
I'm sorry, a lot of disturbance.
Can you hear us?
Yeah.
Yeah. So, Dr. Bharti, when we talk about the affordability of anti-snake venom, so how do you think that the government can ensure affordable and accessible and even accurate anti-snake venoms here in India?
See, already I think from this year, the anti-snake venom is coming under price control. So I think now more quantities would be purchased, more quantity would be distributed, and problem still in many states the ASV is free, and the problem is the doctors are not using the ASV despite it being there in their PSCs, CHCs. If you take, for example, Himachal. So now we are there is whenever fresh doctors are recruited, there is a doctor's refreshing course for 21 days or whatever. So earlier nobody used to teach this treatment of snake bite. So now me being there in the training institute, state training institute, we now regularly are training not only doctors, but paramedics, the nurses, whosoever comes, there is one lecture of treatment of snake bite. So that I'm seeing for the last 2 years, that has given a lot of confidence to the doctors, to the nurses. They call me now, how many vials we can give, how to treat. They didn't had any helpline earlier. So if they are not confident, whom to talk to? So now they call me and they seek guidance, and then sometimes they seek non-poisonous or poisonous, they send pictures. So I think there need to be a nodal focal point in each state, and training institutes of each state should do something, train doctors on how to treat the doctors, because they are not taught anything in the internship. In many areas, like in Shimla, we have a medical college in Shimla. We don't get any snake bite in Shimla, but when you are posted in Kangra, you suddenly start getting snake bites. So I think these things need to be seen in a broader context, and somebody in every state needs to take the lead, not only on trainings, but availability of anti-snake venom, and sort of on call. They can, if somebody is not feeling confident, he can call somebody in the state. So I think these things would go a long way to save the lives of the snakebite victims.
Thank you, Dr. Bharti, for that answer. And coming to you, Dr. Rawat, in terms of the I was also mentioning in my intro, there are after a snake bite, there is a lot of amputation which is being done to the patients, and in certain cases, they are completely disabled. So how do you think from the starting level from the first aid to the time the patient is being taken to the hospital, how do you think this can be avoided?
This is actually a very major problem or challenge in the snake bite management, because anti-snake venom is not effective locally due to various reasons, and we are trying to take proper care of the wound immediately after the bite. Firstly, if blisters occur, then we remove the blister fluid immediately and start a proper appropriate antibiotic without any culture test or like that. And another thing is, if swelling increases, only swelling is there, we start with glycerin maxal dressing, anti-inflammatory drugs, and antibiotic, maybe ceftriaxone with sulbactam or tazobactam, and micacin. And if required later on, if severe necrosis there, we may add metrozil. But we have saved many limbs after a Russell swiper bite and cobra bite. These are some of the ones where we have amputated only these 2 fingers. We can prevent the amputations of fingers, as capillaries are very small, and we could not. And we do after starting antibiotic and removing blister fluids. If there is a severe necrosis locally, we wait for the demarcation to occur, and then we debride the wound with the local anesthesia, or if required in spinal anesthesia. Then we continue the antibiotic. Many times we have seen that necrosis is so severe, debridement requires many times, 2 or 3 times. So we are doing this blister fluid removal. We have tried to do some study on blister fluid, but it is not possible due to many technical problems. And these are the wounds. So this patient of cobra bite required debridement for 2 to 3 times, and then we have done skin grafting on him. So patient was young, so it was possible. And this lower down figure, he is a diabetic patient with the cobra bite. He was actually advised amputation in corporate hospital, and he later came to us. We have done skin grafting after proper debridement, but it was total failure. But patient was insisting for second skin grafting, and we have done it. He was diabetic, and second skin grafting is successful, and his limb is saved. So use of proper antibiotic and wound care is very important. This is also a 16 years girl. She had a viper bite and not received anti-snake venom for 12 hours. She was admitted with general practitioner. He thought there are no symptoms, so he had not given anti-snake venom, and she came late to us. She required 5 to 6 surgeries. She 14 years girl, but we are able to save her limb after the tendo achilles muscle repair, and her muscles were also actually totally necrosed. So this is, and we have done a vac therapy, that is pressure vacuum aspiration therapy for the wound. That picture is not with her. This lady also had a Russell swiper bite, and she also needed multiple debridement of the wounds. This wound lasted for 6 months, but patient kept their patience, and we have done skin grafting. She had a mild limping now. She's a severe scar, but her limb is saved. She is also young. So this is a latest patient who had a vascular toxic snake bite, and she is admitted in government hospital. But wound was totally neglected, and she came with severe necrosis on the medial and lateral side of the limb. And we have done this skin grafting, debridement twice. She is old lady. It took a long time, 2 to 3 months for the wound healing. So this is how we are saving the wounds. We are not using very higher antibiotics. We are starting with the only ceftriaxone and micacin, and if needed, we go to the meropenem, add metrozil if there is anaerobic this thing. So this is how we take the wound care, and we are able to save the limbs.
Thank you, Dr. Rawat, for that. like a quick presentation what you also showed to us. Dr. Anup, I want to come to you and ask in terms of the same in the same lines. Like apart from these, like what doctor has also showed us, like what about the what other long-term implications of a snake venom on the body, and is it true that it varies from region to region depending on the type of the snake?
Yeah, definitely. It varies from region to region, and more than region to region. During the climatic changes also, that the nature of the venom and the complications produced by the same venom changes. Sometimes you may get more acute kidney injury. Sometimes the local reaction may be more. So that change can also be possible. So, and I don't think as far as the ASV or the treatment part is concerned, there is no implication on that, because we have only one type of polyvalent anti-snake venom, but as per the indication we will have to administer that, but definitely we'll have to look for all these complications. But the long-term complications because of ASP per se, or because of the snake bite envenomation, like in my experience, is less. But obviously if the patient has already developed an acute kidney injury, etc., definitely the patient can have the persisting renal issues. Those problems are possible. And again, another important complication what we usually observe is like especially the following viper bite, developing a severe hemorrhagic shock, etc. They can develop something like a Sheehan syndrome, where they can have the pituitary failure and later present with other complications. So whenever we follow up such patients, you have to look at that hormone parameters, and the possibility of the pituitary failure should be always kept in mind. And we have seen many patients with those features where you have to put them on hormone supplementations.
Thank you, Dr. Anup. I want to come to Dr. Maya and ask, Dr. Maya, is it true that in most of the cases, it is a lack of the initial response to the snake bite that causes severe problems like these?
So what you're trying to ask me is if we give the antivenom early. So we know that the only treatment which works is the antivenom. So if we give the antivenom early, is it going to help the patients? So the answer to that is a very clear yes. So first is early antivenom saves life. I think there's not much doubt about this at all. So in many of the large studies, we see that the bite to antivenom time, just like you say patient has a MI, immediately you get the patient to the hospital. Similarly, the shorter the time is, the earlier you administer the antivenom, the more the lives are saved. So, but in terms of disability, whether early antivenom will reduce disability, I think we have some evidence in terms of reducing kidney failure. So there have been few studies which have shown that if the bite to antivenom time was reduced, then these patients don't go for acute kidney injury, and thereby they don't go for a chronic kidney disease. So I think we can also say that early antivenom saves kidney, but whether they actually have effects on the local part, like what Dr. also showed, the disability in the local area, necrosis, and whether they will help with the endocrine part, we don't know yet. I think we need more studies for that. So it's difficult to design also. You can't say that we will give early antivenom to this group and complete antivenom to this group. We can't do a study like that. We just have to see how patients come and then make inferences from that. So if you say that by lack of initial response that patients who are not receiving antivenom early, they're going to have more problems, yes, that is true. And that's one of the important messages we need to give out in the community, that reach as early as possible. If you reach maybe within an hour or within 6 hours, because most study go within 6 hours, then the results are very good. The later you reach, then the venom is already bound to tissues. It's already started causing damage. The circulating venom is not there, and at that point, there is not. We don't know how much antivenom will work. So earlier antivenom is definitely better in terms of reducing deaths as well as disabilities.
So Dr. Maya, you're telling like the patient should reach the hospital within an hour max, and you're telling like minimum, and the maximum should be like 6 hours.
So we cannot, these numbers are not set in stone. So if a patient is going to come to me at 12 hours after the bite and has some envenoming features, I am going to give antivenom, not just me, any clinician is going to give antivenom. We do know that later you give antivenom, the effect is less, but it is not zero. So yes, we are going to give antivenom, and the earlier you give antivenom, it is better. So this 1 hour, 6 hours are all artificial numbers which we get from studies, that what has been used in studies. So, but for us, I think it is important to say why 1 hour. If patient is coming within 10 minutes, it's even more better. So earlier you come to the hospital or in a place where there is antivenom. So that's why antivenom availability in the periphery is also important. You've definitely touched upon initial dosage and how we need to educate healthcare workers for initial dosage, appropriate dosages, referrals, and those things. So yes, earlier antivenom is administered, the better it is. There is no doubt about it. But these timings, I don't think we can set them in stone. Earlier the patient comes, the better it is.
Thank you, Dr. Maya, for that. Dr. Alden, I would like to come back to you again. To understand, like according to WHO, it is said that like difficulties in ensuring proper regulation and testing of all the antivenoms is very important. Also, the after effect and the availability of good quality. So, how do you think we can maintain that in terms of like at your level, the testing of the antivenoms, and then it goes to the the primary healthcare center at the hospitals? How do you think we can maintain that?
Yeah, actually, that's a good question. See, the WHO came up with certain international standards in the year 2010. Unfortunately, to implement them all over the world, it took quite some time, especially in India. And the main reason being, it has to be as per the Indian Pharmacopoeia, which is the regulating body for all whatever the tests we do for release in India. So what happened is that particular pharmacopoeia was supposed to come in 2019-20, but because of COVID, it got a little delayed. Nevertheless, the IPC, that is the Indian Pharmacopoeia Commission, has updated all the monographs with respect to snake venom antiserum, and all the latest testing methods and all, which are fairly now standardized as per the WHO, have been incorporated into the IPC. Another thing is the CDTL lab, which is the Central Drug Testing Lab at Kasauli, which comes under the CDSCO, has a very comprehensive testing process for all these venoms as well as antivenoms. So manufacturing batches are regularly sent to these government testing laboratories before release. But the major concern is actually the quality of venoms, which is directly proportional to the type of antivenoms which we have. So all this is fine for the existing antivenoms. But unless and until we look at regional antivenoms, which are the need of the hour, with broader neutralizing ability in that particular region, it doesn't solve a problem to make an effective antidote for the patients. It doesn't translate into this. So, and I see another 2 or 3 years before a regional antivenom comes out into the market. But studies are ongoing. We are one of the manufacturers who's working towards those.
Thank you, Dr. Alden, for that. And I hope you and your team keep working to find out some best and a good solution for this, and come up with more antivenoms to cure this snake bites in India. Dr. Bharti, if you are here and you can hear me, coming to you and coming to almost this end of the sessions, I have to want to take a quick points to everyone. The first one, I would like to start with Dr. Bharti. How do you think that how can the gaps of accessing real and accurate data on snake bite can be addressed? We also spoke this in the earlier panel session also. We need to know more data. We need to have a real data about the number of snake bites happening in around India, keeping in mind the regions, what Dr. Alden was telling, that each regions can be separated in those terms. How do you think we can reduce those gaps here?
See, the most important is to generate data, and many people are now generating data on the snake species in different parts of the country. And I think that is a great evidence that like in Northeast, we have species, none of them are there in the antivenom. So there is no use of giving antivenom. So at one time we say don't go to the faith healers, and at the same time we know that the antivenom existing is not working against the species that are there in the Northeast. So I think this issue has to be resolved. First and most important issue is more and more we should collect species and then do more venom antivenomics trials to press upon the government that these antivenoms are not working regionally. And the second is number of snake bites. So that is also a different game altogether. In one of the PSCs in Northeast we went, they have not seen any snake bite. But 3 kilometers away there is a faith healer. He has seen 39 snake bites in 4 months. So people not going to the PSC, people are going to the faith healer. So that is a huge gap that needs to be bridged. So I think gap in the number of cases, the gap in the species, then antivenom genomics effectiveness, and then to press upon the government for the right decision based on the evidence. I think these are the things, a Herculean task. All of us has to work together to bridge these gaps. Only then we can think of having a rational antivenom policy and rational treatment for snakebite.
Thank you. Yes, thank you so much, Dr. Bharti, for that. Dr. Rath, I want to come and ask you in like a concluding one, like our healthcare systems need to be more responsive, and we need to accommodate the needs of circumstantial, like of the survivors of the snake bites and their families. How can we do that and
Yes,
bring a change?
this is a very important question. Health centers should be made more responsive. There should be a doctor should be available there round the clock. That is first important thing. And 10 ambulance can be used effectively. 108 ambulances, and patient should be reached to the hospital at the PSC earliest, and they can start the treatment. So that training will help giving confidence to the medical officers, and they will be able to treat patients at the primary level, and then patient can be transferred once he's stabilized. So this is a very important point, and all the most important point is training of the medical officers, I think. So this will definitely help in managing patients at the primary health center level. So about availability of the equipments and the infrastructure, that can be done after the post-COVID. All the equipments are available. Proper distribution is most important. So I don't think there is much issue regarding that.
Thank you so much, Dr. Rao. Dr. Anup, Dr. Anup, in terms of the when we talk about the entire treatment process, but before that, there's something called the myth in the people, and that is also bringing a negative impact on the entire treatment process. So, how do you think we can improvise this and create a small awareness amongst the people about the snake bites?
As we have already discussed, the education is the only solution for such things. The myths are actually there in all the parts of India, even in Kerala. Even though we claim that all are educated, even the myths are too high in Kerala also, especially the snake bite and the snakes are concerned. So that need proper education, and again we have to teach them like what are the issues with snake bite and what are the first aid. Like what is the proper treatment available, all those should be educated very well, I feel. And before concluding, I just want to ask Alden one thing. Like we are, I've already told, we have many the pit viper cases here, and especially hub-nose pit viper patients developing all the complications, and we don't have any treatment options. So, like, do you have any research or any possibilities of coming up with the monovalent antivenoms, especially for pit vipers or any other types of snake bite in India? So how's the research and the business aspect developing in that?
Yeah, so as I mentioned earlier, we are working closely with the Indian Institute of Science. They have a tie-up for getting the hump-nose pit viper venom. And probably in the next 2 or 3 months, we should collect enough venom for doing some neutralization studies and everything. So once we do that, we will characterize the venoms and then try and immunize the animals and raise antibody. But that is definitely on our cards. Karnataka government has been very progressive in allowing hump-nose pit vipers to be captured and milked so that, we can get the venoms. Yes, sir, that's on the cards.
Thank you, Dr. Anup and both Alden here. Dr. Maya, a concluding line from you in terms of the awareness, like how can we ensure awareness creation and the capacity building of the latest snakebite treatment protocols in the published and even circulated by the government of India should be improvised, like in terms of the standards with the WHO, like amongst all the medical communities.
I think the public awareness part has already been touched upon. So if you want to say that how do we increase awareness among the healthcare professionals, it has to happen at various levels. So yeah, now things are happening. Yes, if we see what are current initiatives, several state governments have, like Dr. Bharti has mentioned, they have taken initiative to train the incoming doctors at their intake and include a module on snakebite. There are a lot of efforts which are going on. Even in the previous session, I think that point has been touched upon, where healthcare professionals are being trained, but mostly by which is not in the system. So currently, also our I think National Health Resource Center, which is the technical body for NHM. So they are also trying to bring up some materials and like let us say modules for emergency physicians who are posted in CHC. So those are also including some pathways on snake bites. So I think these kind of we need at various levels. One is at the PHC level, what is the training, and probably if this can be standardized nationwide, and continuing education program kind of thing can be developed for the PHC doctors and other healthcare workers, and we have a curriculum that this will be taught, and this will be updated every 3 years, let's say. So that they know the current protocol. So as far as antivenom is concerned, yes, now we have only one polyvalent antivenom, and the national protocol and the WHO protocol are recommending the same thing. So this just needs to get translated. And like Dr. Bhaji has rightly pointed out, the responsibility also has to be taken by people by us medical practitioners who are in the state to start and initiate these training programs. That's my point of view.
Thank you, Dr. Maya, for that. And I would like to end with Dr. Alden. Dr. Alden, how do you think, like you already spoke to, you were telling Dr. Anup about the new research, what you're doing at the different states in India. So how do you think are we set in manufacturing a new set of antivenoms in terms of the technology and the processes? And what are the hopes we can have, like in terms like in future we do not have we do have less cases. First, we have very less cases of snake bites, and then how we can reduce that with the antivenoms available.
See, with respect to technology and processes, we are not far behind. This product was a very old product. It was designed, the first product designed for antivenoms was in 1895. After that, since the 1990s, there have been very progressive changes. We were the first ones to implement caprylic acid purification of antivenoms on a manufacturing scale, first in the world in 1998. Successively, what we have done is we've implemented risk-based strategies for manufacturing of immunoglobulins, wherein we do disease screening of the animals by PCR, so that any of the diseases which are there are not transmitted. Risk-based assessment. We have virus validation steps which are implemented in the manufacturing, which include low pH enzymatic pepsin digestion. We use caprylic acid precipitation, chromatography, nanofiltration. The immunization practices which we have implemented since the 90s have got such high specific activity, which means very, very low heterologous proteins antibodies are going into the patients, which could give reaction. So all these technologies, in fact, we've been publishing at every 5 years, 10 years, whatever updates we are doing, we put it in the public domain on the latest research which we do. And it's interesting, we are not far behind in terms of technology or processes. We are at par with anybody, any international brand which is selling in international markets.
Thank you so much, Dr. Alden. And we hope we keep I mean you and your team keep doing a good work in terms of your technology and come up with more better solutions for with the snakebite venoms. And I would like to thank all our panelists here. I would like to thank Dr. Bharti, Dr. Raut, Dr. Alden, you and Dr. Maya and Anup for joining us for this entire panel session. And on behalf of the IHW Council, we would like to thank everyone for joining us and talking about creating awareness about a very important aspect about the snake bite and how one can manage it, with what time we should reach the hospital, give treatment, and in terms of the awareness that there is a solution there available, and people should not be scared and should not take another way to treat their snake bites. Thank you so much, everyone, for joining us. And on behalf of the IHW Council, I would like to thank everyone. Like for the second edition of the Snakebite Summit, we hope we see you all next year with some more interesting panel discussions we'll be having, and much more better solutions to this, and maybe we create more awareness throughout this year. Thank you, everyone.
Thank you. Thank you.